Good morning, everyone. My topic today is Angels versus Demon. I am presenting in behalf of Medicine 3. So, on 2011, Mrs. Z, during her routine pre-employment workup, she was noted to have young onset hypertension. She was admitted in the ward for evaluation of young onset hypertension workup. At that time, she had no specific complaints like decreased urine output, diminished vision, headache, or exertional dyspnea, nor past history like stroke or myocardial infarction, nor congestive cardiac failure. She had no claudication pain, limb numbness, or neck pain. She had no known prior comorbidities. On examination at that time, she was conscious oriented, no pallor, no icterus, no cyanosis, no clumping, pedal edema, or lymphadenopathy. Pulses, there is a discrepancy of pulses over both right and left side. And blood pressure is also, there is a discrepancy over her right arm, left arm, 160/80 in the right arm, and 156/80 in the left arm. And right leg, the systolic of 100, and left leg, it is 112. Her JVP was not elevated. An investigation part as HB was 12, MC was 88, creatinine was 0.55, and at that time they had did 24 hours urine metanephrine level, and which was 155, and 24 hours urinary normetanephrine level was 229. Serum cortisol was 8.83, TSH of 4.21. The renal artery Doppler, which is suspicious of renal artery stenosis. So this was the chest X-ray taken at that time. So a female of childbearing age with young onset hypertension with discrepancy of blood pressure in limbs. It's a type of vasculitis. Can you guess? So initially suspect of Takayasa arthritis was suspected, followed by which an abdominal iotogram was done. Her arch angiogram showed as all arch vessels were normal. On abdominal angiogram, it showed 50% narrowing of abdominal aorta with a systolic gradient of 49 mm. And also there is 50% stenosis of the left renal artery. She also had two renal arteries over her right side. One supplies the upper pole of the kidney and the other supplying her lower pole of the right kidney, which both. So this is a case of Takayasa arthritis type 4. So followed by which subsequently percutaneous transluminal angioplasty was done with stenting of abdominal aorta. She was also started on steroids and was planned on slow tapering along with azathioprine 150 mg once daily. She had no coronary or pulmonary arterial involvement at that time. 2018, an abdominal angiogram was repeated, which again showed the abdominal stent has discrete 50 to 60% stenosis with 40 mm systolic gradient with the normal left renal artery, followed by which percutaneous balloon angioplasty was done. At this time, she was also started on antiplatelets and statin. So now she is 28 years old. Mr. She actually presented to the OPD for a second pregnancy with high blood pressures. She had no specific complaints now. She was admitted in evaluation for a chronic secondary hypertension and also to control it. On this presentation also, she still had discrepancy of blood pressures. And previous obstetric history, yes, she had the previous history. She had gestational diabetes mellitus. It was uneven full and it was done by elective LSCS. And she had a single live baby of 2.26 kgs. There is no significant family history. Current examination wise, her blood pressure, there is still discrepancy of blood pressures in both upper limbs as. And investigations wise, the hemoglobin is 11.6 and no other organ involvement. ESR was 45 and CRP was 3.6. So how do we approach a patient of Takayasa arthritis and pregnancy? So first, I would want to say a glimpse about Takayasa arthritis. It is a chronic inflammatory progressive idiopathic arteriopathy. It has many names. It is also called pulseless disease, arthritis, young female arthritis. It usually affects young women of childbearing age. Usually second and third decades of life are more affected. And it is more among women of Asian origin. It mainly affects aorta and its branches, but it can also affect other systemic large arteries. Rarely, it can also affect the coronary as well as pulmonary arteries. It can cause narrowing, occlusion, and even aneurysms too. So why does it occur? Etiology-wise, there is no pathology-wise, there is no clear etiology. It is an autoimmune condition, but specific antigens for triggering the response is not yet identified. And Takayasa arthritis, there are many types. Type 1, type 2, type 1 to 5. The type 1, actually, there is involvement of aorta, branches of the aorta, and type 2, ascending aorta, aortic branch and its branches were involved. And type 2b, it is ascending aorta, descending aorta and its branches. And type 4, it involved descending abdominal and thoracic aorta with renal arteries. And sorry, type 4, it involves abdominal, thoracic aorta with renal arteries, and type 5 is entire aorta. So is there any classification or criteria for diagnosis of Takeusa arthritis? Is an ACR criteria 1990. There are 6 criteria among this. Of this, 3 out of 6 criteria, if it is present, it can be considered for diagnosis of Takeusa arthritis. The criteria is age at disease onset less than 40 years. If there is some claudication of extremities, decreased brachial artery pulse, and blood pressure difference greater than 10 mmHg, and bruit over subclavian arteries or aorta, and arteriogram abnormality is present. So stages, usually it present with, actually it has 3 stages. Stage 1, it is actually pre-vasculitic systemic stage. The patient presents with constitutional symptoms. Stage 2, it is an inflammatory phase, and stage 3, burnt out stage, it is a stage of remission. So although Takeusa arthritis mostly affects women of childbearing age, there is a paucity in the literature of pregnancy associated with Takeusa arthritis. Pregnant women are at more increased risk of cardiovascular complications, including hypertension and congestive cardiac failure, which may jeopardize both maternal and fetal outcomes. So approach to Takeusa arthritis in pregnancy is, first question, can they conceive or not? If yes, when? And what are the complications associated with pregnancy? If there is a disease flare in pregnancy, what treatment can be given to them? And what can be the mode of delivery preferred? So as per the first question, Takeusa arthritis, it neither affects pregnancy nor is exacerbated by the pregnancy. However, to achieve favorable maternal and fetal outcomes, it is preferred that pregnancy is to be planned on remission phase. There are many studies. One among them is by Hidaka et al. It is a retrospective study involving 24 patients. These patients were in remission. They showed good maternal as well as fetal outcome. Despite if the patient is in remission or they showed improved symptoms, still they have to be considered as high risk patients. And very important thing is, so antenatal counseling and pre-conceptional counseling is very important to assess the disease activity, to optimize the blood pressure, and to eventually change the medication which are compatible with pregnancy prior to conception has to be recommended. And during this pre-conceptional counseling, we have to switch potential teratogenic medications with those considered safe during pregnancy. And second thing, all Takeusa arthritis patients, either they are pregnant or not, we should closely monitor for both hyper as well as hypotension. And most important complication and most common complication of arthritis in pregnant women is hypertension and its complications. They can go for hypertensive retinopathy, hypertensive related congestive cardiac failure, dilated cardiomyopathy, and fetal outcomes like premature baby, premature delivery, intrauterine growth retardation, and so on. Now, many studies, a study of 89 gravid patients with Takeusa arthritis reported higher rates of prematurity and low birth weight than those without hypertension. So the overall complications wise, it is the 3 times there is more risk in active than inactive patients. So these are some of the studies of patients with Takeusa arthritis they presented, and the maternal complications they had. Some present with uncontrolled hypertension, some present with GTCS, some present with eclampsia, and so and so. And some of even normal delivery was done, and some of them MTP was done, elective LSCS was considered for them, and outlet forceps was done. And next is, if a patient had a disease flare during pregnancy, what should we do? So usually we should intensify our medical treatment according to flare. Suppression of disease activity, the main part we should consider is treating them with steroids, and also we can start them or associated with some, which is the cornerstone to improve outcome. If there is a life-threatening condition, we can even consider medical abortion or premature delivery. So how do we know if a patient is in active phase or not in a pregnancy? There is no reliable criteria for progression of disease activity, and there are no specific biological markers too. We can consider inflammatory markers like ESR, CRP, fibrinogen, haptoglobin, but however, they are imperfect reflection of activity of the underlying disease. The active disease can be, it is even possible in 30% of patients with absence of inflammatory markers. There's some other biological markers like RANTES, TNF, alpha, interleukin 6, and pentraxin third and VAFF, but they are not routinely achievable. So there is one more criteria called National Institute of Health Activity Criteria. This is based on it is based on a prospective study involving 60 patients. So based on this criteria, if there is a recent onset or worsening of at least two of the four criteria, which are signs of ischemia or vascular inflammation, like claudication of limb, decrease or absence of a pulse, blood pressure asymmetry, or if they have some systemic symptoms which are not attributable to other events like fever, arthromyalgia, angiographic abnormalities, or increase in inflammatory markers like ESR, CRP, fibrinogen, and haptoglobulin. Out of this, two of the four, if it is positive, we can consider as a active disease activity. So some tests to follow up on Takayama arthritis by positron emission tomography has been performed, but the sensitivity and specificity is unknown. So treatment during pregnancy, if the patient is in remission, they can continue the same drugs what they were on, but we can consider making them switch to a safer drugs in pregnancy. But what if there is a flare? In inflammatory phase of the disease, oral corticosteroid therapy is the specific reference treatment. We can, in combination with that, we can also add some immunosuppressants like methotrexate, azathioprine, mycophenolate mofetil, and targeted biotherapies like anti-tumor necrosis factor alpha and anti-interleukin 6. Methotrexate is usually considered teratogenic during pregnancy. So azathioprine is usually considered safe during pregnancy. And steroids can be started on a dosage of 0.5 to 1 mg per kg per day, and you can slowly taper it. So why to slowly taper? To identify the possible effective minimum dose to keep tachycardia in remission, and also to allow adrenal secretion to recover. So corticosteroid therapy is the most effective, is considered very effective when the diagnosis is made in the pre-occlusive stage. I can achieve remission in 25 to 50% of cases. In National Institute of Health prospective series of studies, 48 out of 60 patients had signs of disease activity. Of them, with steroids, 25% went into remission. 16 patients relapsed and they were treated again with steroids and they went into remission. So this is 2018 EOLAR algorithm for pharmacological treatment of Takayama arthritis. If we had made a diagnosis of Takayama arthritis, we can start them with steroids along with conventional DMARDs, and we can slowly taper the steroids as per the response. If the target is achieved, we can still taper the steroids and continue on a low dose conventional DMARDs. So if whenever there is a major relapse or minor relapse, we can start them again on steroids. But if there is a second relapse, we can consider adding a tocilizumab or TNF inhibitor. And if they went into remission, we can slowly taper the steroids after that. So methotrexate is the first line for reducing the steroids. Addition of methotrexate to steroids makes remission in 50 to 80% of corticosteroid resistance or dependent cases. But it is considered teratogenic, so it is contraindicated in pregnancy as well as in breastfeeding. We can also consider adding an antiagrants and statins. Azathioprine can be used during pregnancy. And if they are hypertensive, we can we should avoid AC and ARBs to be avoided during pregnancy. So mode of delivery preferred is most patients can have a normal vaginal delivery too. Although the second stage of labor may have to be expedited to limit surges in blood pressure, we can help them with outlet forceps and all. And cesarean section wise, it is usually reserved for severe hypertension, severe aortic regurgitation, and obstetric indications. Breastfeeding is most often possible. Breastfeeding is compatible with prednisone, azathioprine, or infliximab. As of methotrexate, it is better to wait for 24 hours after taking to breastfeed a child. Significant concentrations of cyclophosphamide isn't usually in breast milk, so better avoid if a patient is taking cyclophosphamide. And take-home point in this is Takayama arthritis in pregnancy is always considered a high-risk pregnancy, even the patient is in remission or if there is a disease flare. So it is better the conception should be planned only after remission is achieved and if contraindications to pregnancy does not exist. So this is a early diagnosis and vascular damage assessment and invasive therapy and immunosuppressive therapy. These are the 4 points. Thank you.
What is one clinical take-home point you want to give? Young women who come to you with hypertension in pregnancy, look for peripheral pulses. It takes only a minute. Next, we have Vidyadhar. From medicine 5, empty